stretch to 100%, from 100% come back to 70, and 70% stretch apply over the tendon area. Yeah, which will calculate, right?
Why need to stretch 100 and come back?
To desensitize, to decompress the pain. Actually, we have to give 70% of stretch. Okay, so if you go stretch to 100%, you know it is 100 or not, 70 or not.
Okay, understand.
Again, so how much? 100, come back to 70, apply over the tendon area. Okay, and end of the tape, no need for any stitch.
Can see mid of this one until this area, and then one eye strip here over the tendon area. This one, another one, like a X shape. Understand? Thank you.
So how we apply? So first we take a high strength, and how much of length you've taken it? 80% of the from the metacarpal until to the lateral epicondyle. Please on your mic, and I cannot come see the messages.
Inhibitory technique. Is it inhibitory technique? Yes.
Facilitation is for muscle contracting.
Yes, it seems the
Please ask them to on the mic and ask the question.
Open the mic if you have a question.
So for again repeating how to apply, they're taking 80% of length from the metacarpal until to the lateral epicondyle, anchoring the tape over the metacarpal without any stretch. Then how much of stretch? 20% of stretch. How long? Until to the lateral epicondyle. So once after lateral epicondyle, without the stretch, anchor the tape again. This is the first step. Second step, that is a decompression or desensitizing tape. How to apply? Palpate the area of the pain or tenderness, mark the area, take short eye straight, stretch it to 70%. With 70% of stretch, apply over the tendon area in the form of cross. That's like that. Is it okay? Now to the golfer's elbow. Step. So keep the wrist and fingers extended from the middle metacarpal until to the immediate condyle. Right? So we take 80% of the
Susah itu.
Anchor the tape over the palm of the hand at the metacarpal without any stretch. Then remove the upper backing. Maintain the wrist at flexion, so extension, and give 20% of stretch to the tape. Go up along the common flexor tendon until to the medial epicondyle, maintain the stretch 20%. So after the middle epicondyle, no need for any stretch, just anchor the tape like this. How many of you in the weekend? Your class. Five. You got them one?
Dapat.
Yeah,
She very like,
And how she's taking the exam?
yes.
for sure.
Right. So next again, palpate the common flexor tendon over the epicondyle, and we're going to apply the decompression tape.
So it goes like here, isn't it?
Yeah. So how much of stretch? Over the tendon area. Apply the form of end of the tape. No need for any stretch. So under come back to 70. The tendon area. Okay. End of the tape. No need for any stretch.
It will be provided during the exam.
Okay. Now we have to do tape for any silver copper silver.
Either. What you want to say? Now what?
So next we move on to the recent time conditions. Any questions from the online?
No, sir. Understood.
Okay. It's empty case bending. Okay. And then you okay. So when coming to the lesson hand conditions, we have TFCC injury, carpal tunnel syndrome, decrovine stenosynovitis, decuttance contracture, and gamekeeper stomach. These are some of the conditions we will discuss now. I don't know how many times when they're on the mic and what's the problem for them to on the mic?
There are different type of tapping technique used for tennis elbow.
It's a question.
There are different type of tapping technique used for tennis elbow.
You can do whatever you know. Okay, until the purpose is achieved, you can follow this or whatever you know, you can do it. Okay, the purpose is you have to protect the structure. Inhibition. For inhibition, you apply 20% of stretch, and for the pain, to reduce the pain, we are giving 70% of stretch for the tendon area. That's a basic principle. Okay, so if you have any other type follows the principle very well, you can apply, no problem. Got it? Right. So next we move on to the risk and conditions. I shall start with the TFCC. TFCC is triangular fibrocartilage complex. Okay, triangular fibrocartilaginous complex. It's a complex of structures. Complex means what? Several structures are there. So it is found between the ulna and proximal carpal bone. Between the ulna and the proximal carpal. Why it is there? What's the reason for this? Why not between the radius and carpal bone? Why only between ulna and carpal bone? This TFCC is located between ulna, that is the end of ulna, and to the carpal bones. Reason is, yeah, not the movement. Anatomically, the ulna is more proximal than the radius. Okay, ulna is more proximal, radius is somewhat distally placed like this. Consider this is the ulna, this is radius. So there's a gap. Consider this is the carpal bones. So this carpal bone, this is the radius, this is ulna. So you can see the gap there. Yeah. This gap is of the TFCC. Okay, what are structures is? One is the articular disc. Disc. Then we have meniscal homolog. Meniscal homolog. Then ulnocarpal ligaments. Okay, and the tendon sheath of flexor carpi ulnaris. Right. This all will form a triangular structure. That is the TFCC. Basically, it's soft tissue. Right? So, as the soft tissue, this may go for a damage, injury. The most common cause is falling with outstretched hand, with the shoulder extremity, like our PLR. Okay, outstretched hand is the most common reason. Mechanism of injury. So how we can identify this condition? We can palpate the TFCC. To palpate TFCC, no problem. To palpate the TFCC, follow the ulna, come down, and you can reach the head of the ulna. This is the head of the ulna, and it has a styloid process. So, we identified the head of ulna and styloid process. Cameras focusing on, check it. Okay. That's bring it forward.
Huh?
Okay. Right. So we're following the ulna and reaching the, what is the part? What is this? Head of ulna. Head of ulna. Okay. And the tip of that is the styloid process. Got it? So, and from there, if you come down here, this is our carpal bones. What's the carpal bone here? What's the carpal bone here? Triquetrum. Okay, it's a triquetrum and pisiform is here. So between the triquetrum and the head of the ulna, there's a gap. That gap is the place where your TFCC is located. Okay, this is the place. Okay, this is the location. Between the head of ulna and the triquetrum, you can feel the TFCC. Okay, now, while you palpate TFCC, is any pain is there, and that we call as a fovea sign. F-O-V-E-A, fovea sign. Tenderness over the TFCC. F-O-V-E-A. Okay. And then we can do some special tests to confirm the problem. The first test which we can do is a TFCC compression test. TFCC compression test. So the patient should be seated. Therapist standing on testing side, come closer. So keep the elbow flexed to 90 degree, forearm supinated. Stabilize the forearm with one hand and place the other hand over the wrist hand. Keep the wrist in neutral position. So it should not be extended or flexed. It should be neutral position. Okay, and then apply axial loading using the top hand. Use the top hand and push it down and down towards the wrist joint. That is the axial loading. So apply axial loading. Maintain the axial loading from ulnar deviation. Got it? Okay, apply axial loading and then ulnar deviate the wrist. Check with the patient, any pain is reproduced. So while ulnar deviating, don't extend the wrist or don't flex the wrist. You should be in the same neutral position. Neutral position and just you have to ulnar deviate it. Correct? So check with the patient, any pain is reproduced. If pain is there, consider test is positive. This is TFCC compression test. Okay. Any questions? Axial loading and ulnar deviation. Okay. Next test for the same condition. TFCC ulnar grinding test. TFCC ulnar grinding test. So to perform the test, same position. Flex the elbow 90 degree, forearm supinated. Again, fix the distal forearm and place your hand over the wrist and hand in this way. Now again apply axial loading. Apply axial loading, maintain axial loading, extend the wrist to the maximum with axial loading. Extend the wrist to maximum with axial loading. Following the extension and then grind the wrist towards ulnar side. Got it? Again, repeat. Axial loading, maintaining axial loading, wrist extension, maintaining the extension and axial loading. We have to grind the wrist joint towards the ulnar side. Okay, and check with the patient any pain is reproduced. Pain is reproduced, test is positive. Any questions in online?
No, sir.
Thank you.
Waiting.
Yeah. The third test for TFCC.
Sir?
Yeah.
For example, if you do the grinding test,
Yeah.
and then the patient complain pain,
Mhm.
but you just want to do another test, which is you do the first one, the compression test, but patient doesn't feel pain. So how do you want to consider? Is it a positive or is it?
For this, I have answered. Don't diagnose any condition with a special test. It's a confirmatory test. So from all your assessment, from chief complaints, from the history, the palpation, everything give you a positive finding. Finally, confirming your condition with the stress test. So first thing is don't diagnose any condition only with the special test. If you can even diagnose condition with the special test, means why do you do all the assessment? Okay, it's a confirmatory test. Confirm the problem, you're doing the test. The next test for TFCC is piano key test. Piano key test. So to perform that test, again, seated, therapist and testing side. Okay. Then one hand stabilize the radius. Use a grip like this, like a hook grip. Stabilize the radius. Place your thumb over the head of ulna. Over the head of ulna, and try to push the ulna, the head of ulna down. Push the head of ulna down like this. Applying a downward force. And check back how far the ulna is displaced. This is a normal displacement. If there is any instability is there, when applying the force, when trying to push the ulna down, the ulna will be sinking down and comes back, like how you're pressing a piano key. It goes down deep and again comes back. That floating kind of feel will be there. So if that is the excessive displacement of the ulna is considered positive. Okay, so how are we going to do? Stabilizing the radius and place the thumb over the head of ulna, applying a downward displacement and check how far it is displaced. Any excessive displacement of the ulna, consider positive. Okay. Any questions? So these are the three tests we can do for TFCC. Compression test, grinding test, the piano key test. If you don't have any question, I can move to the next condition. That is carpal tunnel syndrome. So the carpal tunnel is get compressed. The tunnel is formed by carpal bones and the flexor retinaculum. It forms a tunnel through which neurovascular structures passes through, particularly our median nerve. If there's any collapse or compression of the tunnel, compresses the median nerve. Okay, so median nerve supplies the lateral three fingers, the thumb, the index finger, and the middle finger. This is supplied by the median nerve. And nerve supply to these three fingers will be decreased, causing sensory and motor problem, like sensory deficit, numbness, paresthesia, tingling sensation will be there, and the thenar muscles will go for wasting. The four thenar muscles may go for wasting and causing atrophy, and decrease the functioning of the hand, like grip functioning, holding, gripping will be affected. Why it is that? What's the cause for this? Many reasons are there. One could be maybe due to obesity. It can happen in pregnancy, edema, or any fracture. Okay, these are some of the reasons for this problem. So how we can identify this problem? So we can palpate the carpal tunnel. Can you remove the tape? You want it? Then do it.
Alah, ini lah. Very slow lah. Dulu tangan dia apa? Dulu dia apa?
Right. So we can palpate the carpal tunnel, which is on the carpal bones. So this is a joint. This is the carpal bone. So between the thenar and hypothenar area or the carpal bone area, this place we have to palpate. Okay, so palpate the carpal tunnel and check is there any pain or tenderness. The possibilities are there. Okay, sometimes when you compress in tunnel, patient may feel a shock kind of feel also will be there. Right, so you can palpate the carpal tunnel, then check for the muscles, the thenar muscles wasting. Also, sensory examination is very important. In examination also, you can perform sensory examination, checking the prick. Okay, and soft touch, everything you can do and check this sensory deficit is there. Right. When coming to confirmation of this problem, we can perform carpal tunnel compression test. Carpal tunnel compression test. So to perform the test, patient should be seated, therapist standing on testing side or seated, no problem. And palpate the carpal tunnel, apply compression and maintain the compression for 30 seconds. Pain. Then the problem is done. That's a positive finding actually. Okay, so apply compression and maintain the compression minimum 30 seconds, maximum you can maintain about 2 minutes also. Maintain the compression for 30 seconds. After that, check with the patient any neurological symptom is reproduced, like tingling sensation, okay, or numbness is there, paresthesia is there. If any neurological symptom is reproduced, consider test is positive. Okay, this is the carpal tunnel compression test. Next, you can do the phalanx test. I think you all know the phalanx test. So I'm going to ask the patient to abduct the shoulder, flex the elbow, keeping the wrist flexed. Okay, maintain it for 1 or 2 minutes. And after 1 or 2 minutes, check with the patient any neurological sign is reproduced with the 3 fingers. That is a phalanx test. Next, we can do tenal sign. T-I-double-N-E-L. Tenal sign. Yeah. So identify the carpal tunnel, use 2 fingers and tap over the carpal. Okay, just tap over the carpal tunnel and check with the patient is there any electrical shock kind of feel is there down the fingers.
During our diploma, actually, discharging force macam tu.
Yes, can be done. Okay. Yeah, if you start from here, you can go down, and from here you can go proximal also. That shows how far it is compressed. Any questions?
No.
So these are 3 tests we can do for the carpal tunnel. So we can do carpal tunnel compression test, balance test, and tenal sum. Next, we move on to the decrovines tenosynovitis. Decrovines tenosynovitis. It's basically a inflammation of tendon sheath. Inflammation of the tendon sheath. Which tendon? Abductor pollicis longus, extensor pollicis brevis. Okay. Abductor pollicis longus and extensor pollicis brevis. These 2 tendons, which originates from the forearm and comes down, crosses the radial styloid process. Okay, moves, became a tendon. As a tendon, it crosses the radial styloid process and then inserts over the metacarpal and the proximal fluids. Right. Now, during repeated wrist movements like ulnar deviation movements and example carpentering work, plumbing work, writing work, typing works. Okay. So in those kind of movements, what happens? The tendon may have friction over the radial styloid process. Over the radial styloid process, you can see the tendon. The tendons may have a friction. So due to the friction, what happens? The tendon sheath, not the tendon covering. Okay, may go for inflammation. That's why it's called as tenosynovitis. If a tendon is inflamed, this is tendinitis. If the tendon sheath is inflamed, it is tenosynovitis. That's the condition. So we can identify the condition by palpating over the radial styloid process. This is the radial styloid process, and this is the 2 tendon. If you can't see the tendon, just abduct the thumb. You can see the tendon. You can see the tendon here, right? Okay, identify tendon and apply a compression force over the tendon. Check with the patient is there any tenderness is there. Okay, so tenderness is there. Consider that is inflammation. This is palpation. Okay, now coming to a special test, we can perform Finkelstein test. Finkelstein. Finkelstein. Finkelstein test. Can you switch off the aircon? There. Yeah. So to perform the test, patient be seated, therapist seated on the testing side, and keep the forearm supported on pillow. Okay, but the wrist and hand should be out of table. Relax. Okay. Keep the wrist and the hand out of the table. When you keep the wrist and hand out of table in relaxed position, this itself causes some amount of ulnar deviation. Again, check with the patient whether this is painful. Sometimes in chronic stages, this itself causes pain. Now the patient says, I don't have any pain. Then stabilize the forearm and ask the patient to do ulnar deviation. Right? Actively. Check with the patient. Maintain the ulnar deviation. Check with the patient whether this is painful or not. If there is no pain, then what you do, you apply over pressure. Further, ulnar deviate the wrist. Check with the patient. Now, again, pain is there or not. Still there is no pain, and then you passively adduct the thumb. Got it? Check whether there is any pain is reproduced. This is a Finkelstein test. So how to do the test? Keep the wrist hand out of the table and check due to gravity assisted ulnar deviation, any pain is there. If there's no pain is there, ask the person to ulnar deviate actively, maintain that. Still there is no pain, apply further force for the ulnar deviation. Check if there's any pain is there, still no pain, and then passively adduct the thumb. Yeah, okay, and check with the patient is any pain is reproduced. Okay. Any questions? Right. One more test is there. That is Eckhoff's test. EICHHOFF. EICHHOFF. Apostrophe S. Eckhoff's. Starting question is the same. Now, in the doing the test, ask the patient to make a fist and then ulnar deviate to the maximum. Okay, check with the patient, any pain is reproduced. No pain is reproduced, stabilize the forearm, you further apply the stretch. Okay, check with the patient, any pain is reproduced. This is Eckhoff's test. Any questions? Online?
How good, sir?
No.
Is it because can be applied like this?
Huh?
Like this, freely like this, or need to
Need to?
yeah, just below.
That is always we have to give comfort and support the part, isn't it? That is one of the primary criteria of doing any assessment or treatment, whatever it is. The part has to be stabilized. So this is the first stabilizing the part. That's it. Any questions online? No. Right. So next we move on to the Dupuytren's contraction. Dupuytren's contraction. So basically, it is the contracture of palmar aponeurosis and palmar fascia. The palmar fascia or the aponeurosis may go for a tightness, contraction. Why this happens? Most possible reason is genetic. Okay, yeah, hereditary. Or it may happen following any infection, open wound to the hand. Also a reason. Sometimes also happens following rheumatoid arthritis, like autoimmune disease. Okay, rheumatoid arthritis, even gout. These are the cause of the problem. So how we can examine this? Basically, by looking at the patient by the hand itself, we can get an idea. Okay, what is that is when there is a contracture is there. Okay, the pliable softness of the hand will not be there. If you touch here, you will know it is soft. But in case of the Dupuytren's contracture, the area palm of the hand will be very rough, very tight and rough number one. Then next what happens in later stages, the fingers, particularly the little finger and the ring finger, starts flexing. Why? Because the long flexor tendons, the flexor digitorum superficialis and flexor digitorum profundus, which attaches to the middle phalanx and distal phalanx, they will be pulled. When these tendons are pulled, what happens? The finger starts flexing. Initially, the little finger and the ring finger flexes. As it becomes chronic, all the fingers also starts flexing. Okay, second. Third, the palm becomes cupping like this, where your upon opposition of the little finger and the thumb takes place like this. Getting? Cupping of the hand will happen. When the hand becomes cupping, automatically the palmaris longus tendon will be more prominent. Do that. Palmaris longus tendon will becomes more prominent. Usually, we cannot feel that. When cupping happens, the palmaris longus tendon, you can see it will be more prominent like this. Okay, yeah, can you do it? See, it becomes more prominent. These are the features. That's why I told you, by looking at the patient, they can identify. So one is palpate the palm. Is there any rough, tight feel is there? Check whether the fingers are flexion taking place, then the cupping of the hand is there or not, and also palpate the palmaris longus tendon. So that gives an idea about this condition. And actually, there's no social test for this condition. But what we can do is, we can ask the patient to place the hand on the table, okay, and just observe this. Still, you can feel the cupping of the hand will be there, right? And then ask the patient to press down and spread the fingers. They can't do that. Understood? Okay, and still the cupping will be there, and the fingers will be flexed like this. It will be maintained. And that gives idea positive. Any questions? Those online? No questions? Next condition. That is a gamekeeper's thumb. Gamekeeper thumb or skier's thumb. It's a common problem with the gamekeepers, goalkeepers, and skiers. So basically, what happens here is the MCL ligament of the first MCP joint, metacarpophalangeal joint. Okay, metacarpophalangeal joint. The MCL ligament will go for a damage. That is a condition. It's very common in goalkeepers. When you're trying to catch the ball, you're keeping like this, and instead of holding the ball on the palm, the ball comes and hits the thumb. The thumb goes for hyperabduction and hyperextension. That stretches the ligament. Okay. Other reason is in skiers, the long handle of the skiing. When trying to push forward acceleration, the handle keep on applies pressure over the MCP joint, causing a valgus stress to the joint and damages the MCL ligament. These are the cause for this problem. Okay. Right. Now to identify this problem, we can palpate the ligament. So as it is between the metacarpal and the proximal phalanx on the ulnar side or medial side. So palpate the metacarpal, head of metacarpal, and palpate the proximal phalanx. This is a head of metacarpal, this is a proximal phalanx base. So between these two, the ligament is located. Palpate over here. Okay, palpate the ligament and check if any tenderness is there. If tenderness is there, you can think about the injury. And to confirmation, we can perform the valgus stress testing. Valgus stress testing. to the ligament. Keep the elbow flexed, forearm pronated, fingers supported on the table. Stabilize the metacarpal head with one finger and hold the proximal phalanx, and then apply a valgus force, abduction force, away from the midline to the metacarpal like this. Okay. So apply abduction force away from the midline to the proximal phalanx of the thumb. So while you're doing it, two things you can see. One is excessive displacement of the thumb and pain. So excessive displacement and pain is considered. Okay. This is the valgus stress testing for the MCP joint of. Any questions? Okay, please practice. Thank you. The head of ulna. Maintain that. Maintaining that, maintain the stretch in the tape. Okay. And bring it to the supposing to come until the
Okay, down.
yeah.
Tapi kau hancur sebutan jam lebih masuk.
Okay, again, so start on the dorsum of the palm, not the palm, the forearm. Okay, over the ulnar head, apply the anchor. Then hold the radius, wrist and hand. Apply a distal translation force to the ulna. Maintain that. Okay, and bring it to the like this. Okay. And then take another strip. This we are going to apply over the carpal bones on the palmar aspect here, this side. Okay. Not on the ulna, over the carpal bones. So maintain, hold the wrist hand, apply and stretch towards upwards. Pull it. Which one? The carpal bones. Okay, maintain the stretch. Take and then bring it out sides. Got it? Then take another short strip. I think they are listening. Take a short strip, fold it in the middle. Okay. Apply this over the ulnar side. Understood? Use the same one. And then take a strip. You stretch to the tape, maintain the stretch, and back, bring it back. But make sure don't apply the tape too tight. Apply too tight, the blood supply to the fingers will be decreased. So be careful. So take another strip. Hold it again. in the middle, like before. Okay, apply this on the left side. One more time, but in opposite direction. Mm. Got it? So maintain the stretch. Don't apply too tight, it may decrease blood flow. That's all. This ulnar side will be very stable.
Yeah.
Right? It restricts the ulnar deviation also.
Actually, almost the same, but you make a rule using this form like this. Then you place over the PSC area.
Okay.
And so that.
And
Like
that's
a
an
different,
idea.
different approach. This one will also be like a different.
Like a secure. Yes, secure, right.
Push that
It is very tight. Can you feel it?
Yeah.
Very tight?
Yeah, I think it's okay.
Okay, now. Okay, next to the carpal tunnel, you don't know.
No.
There.
Yes,
Yeah,
yeah.
of course.
Yes.
So for TFCC, that means carpal tunnel. So I'm going to use a KT tape. I'm going to start from the palm of the hand and going all along the course. So I take until here. I'm going to stretch it 20%. Yes. Okay, nice straight. And this, I'm going to cut it to make a short line. Okay. So this, I'm going to apply over the thenar and hypothenar area. Anchor this without any stretch. Okay.
That the position, the wrist must be extended.
Yes. Only problem with the taping is if the patient have a sweating, okay, very oily, the tape won't stick. That's a problem. So we have to clean the hand before applying the tape. Okay. Now give 20% of stretch to the tape. Maintain the 20% and go all along the course of the median nerve this way. Okay, don't go immediately. Okay, so in this way, with the 20% of stretch, apply over the median nerve. Okay, and end of the tape, no need for any stretch. And then again over the tender area or the tunnel area, we can apply the decompression tape. So remove the paper backing. Stretch to 100 to 70. Okay, maintain the stretch over the tunnel area. Right, don't apply over the wrist. Over the tunnel area with the stretch applied. And end it for any stretch. Just place it. Right? This is the cup tunnel. Decurrence tenosynovitis? Yes. Then show to anyone else. So keep the elbow flexed and forearm mid prone position in this way, and keep the rest hand slightly down. Okay. So we're going to apply the tape from the metacarpal until to the origin of the muzzle. So I'll take 80% of the length. I'm going to divide this tape into two because the entire area is smaller. No need for this much broad of the tape. So we can make it as a two, divide into two. There are some tapes where you just flip and it can continue to. Right. So take a short, thin ice strip, and then keep the thumb slightly abducted. Anchor the tape over the proximal phalanx without any stretch. Remove the paper backing and give a 20% stretch. Go in line with the tendon without pasting it. Apply over it over the origin of the muscle. Right? Okay. Now adduct the thumb and paste it over the tendon. So we can do this one more time. Slightly next to the first one. Because we cannot do the tape totally over the first step, it won't stick. You have to keep it in slightly over the skin so that it will stick properly. So anchoring it without any stretch. Remove the paper backing. Okay, ipsic abductor, go along. Okay, 20% stretch and anchor it. Then again, connect it and go along with me. Right, if you see here, I'm just applying side on the sides. Don't overlap it. So next step, decompression tape. Again, same thing. You can palpate the tender area, and you can apply a short ice strip. So mark the tender area to over the radiosternal process. And move the back in. So give 70% stretch. And with that, apply over the tender area. That's all.
So for the wrist, what does it called? The skin? Yep. This,
KFC,
no, I'm.
Kaplan syndrome.
Taping.
So this taping, there's no need to be X like the letter.
No.
Because just small area. Okay.
That's all.
Okay. Okay, sir.
You know what? Minute.
Any questions? Those online?
So like this one. You can follow.
Okay, if you don't have any questions, I give the briefing for the CA exam. Yeah.
I have question.
Huh?
I have question.
Yes.
Do we do the taping after or before we do the manual therapy one?
Pardon again?
Do we do the taping? For example, if I want to do the PNF, do I do the taping before or after the PNF?
I keep the taping at the last option, because if you want to do any other massage or some other technique, that may restricts you. So
see, huh?
keep the taping as a final treatment option.
All
Right. So I go for the briefing for the CA exam. I hope the first CA exam will be presentation. Am I right?
Yeah.
On July, isn't it? Yes. Then when is the case report submission? Case report submission date?
19 July.
19 July. Oh, so same time almost. Okay, fine.
Yes, I'm sharing.
Oh, because it is on June.
Okay, for the presentation, you will provide a case scenario. Okay, for the case scenario, you have to do a presentation, 10 minutes. 10 minutes presentation, 5 minutes discussion, totally 15 minutes. So your presentation should be in the PowerPoint. You have to submit the PowerPoint 1 day before the exam. So what your presentation should be means it should be on the problem listing, pathophysiology of the condition, critical analysis of the problem, clinical implication, and physiotherapy management. I think these details are available in the LMS, no need to write. Okay, you check the LMS, you just open the LMS, you can see the details. Okay, anything additional to that, you can note it down. Okay, right. Make sure the slide is legible, visible. Okay, a minimum 24 could be Arial or Caliber. Make standardized Arial or Caliber 24. Also, please make sure the time allocated for you is only 10 minutes. If you're giving too many of information, you can't be able to complete within 10 minutes. No additional time will be provided. Okay, so you just think about it before dumping the information. Okay, keep whatever the information is important. From the hints you can develop, you can explain more rather than just reading from the slides. Okay. So summary is about the positive findings mentioned in the scenario. Just summarize what are the main positive findings, like any pain is there, or any tenderness is mentioned there, or any limitation of the movement is there. Okay, or any mechanism is mentioned in the scenario. Directly there won't be any word like mechanism of the injury. A history will be there. From the history you have to understand this is the mechanism of injury. Getting? It won't be given any heading like mechanism of injury. We have to understand. Like how a patient comes to you and explaining that I fell down with my hands outstretched like that means, then you have to understand about what could be the structure involved like that. Understood? So an incident is mentioned, a history will be provided. From the history, you have to understand this could be the possible mechanism of injury cause. Okay, so those things you have to highlight, like the clinical features, the signs and symptoms whichever mentioned there, and any mechanism is mentioned there. All this we have to summarize. Getting? And you have to come up with a hypothesis. So based on the problems, whatever they mentioned in the scenario, the problem listing, what are the problems mentioned in the scenario, and the signs symptoms. Now based on this, you have to give a hypothesis. What could be the possible problem of the patient? Right, like a tennis elbow, golfer's elbow, TFCC injury, or carpal tunnel syndrome, like that. You have to this you have to give by analyzing the problem. How you are saying this could be a carpal tunnel syndrome. How you have to relate with all the facts which is mentioned in the scenario. By relating all the facts, you have to analyze the problem. Okay, and from that you have to hypothesize this could be the possible problem of the patient. While analyzing the problem, you have to analyze that with the evidence, literature support. Getting? If you're saying this is a carpal tunnel syndrome, how you are saying this is a carpal tunnel syndrome? Like patient may having numbness is there, tingling sensation is there. Okay, weakness of the thin arm muscles is there. Patient complains of weakness of the hand grip is there. So these are the facts. If there is a weakness is there, means why weakness is there? That you have to analyze. Because median nerve supplies these thinner muscles. As median nerve is compressed, nerve supply to these muscles will be lost and causes the muscle weakness. That is analysis. Understood? If sensory deficit is there, means why sensory deficit is there? The 3 fingers, because median nerve supplies these 3 fingers and it is compressed, the nerve supply to these 3 fingers will be decreased. This is your analysis. Understood? In case of any mechanism of injury, like for a TFCC injury is there, when the patient fell down with outstretched hand, okay, with the shoulder action rotated. So this is the possible mechanism of injury. That's the analysis. This analysis you have to support with literature. Literature support. Literature support. Evidence. Evidence. Okay. There is no limitation, any number of evidence you can provide, but all your evidence has to be within 5 years. This is important. Okay. All your evidence has to be within 5 years. Then you have to slightly go into the anatomical and physiological background of the condition. For example, carpal tunnel syndrome. Okay. A brief explanation about the condition. Explaining the anatomical and the physiological background of the condition. Right? Then you have to explain the pathophysiology of the condition. All this with evidence. With evidence. For everything, evidence is needed. Each and everything, the point, whatever you mention in your slides, everything has to be evidence-based. Literature support has to be there. So this analysis, discussion about the analysis and anatomical and physiological background of the condition, pathophysiology carries 25% of the marks. The case summary and problem listing, 10% of the marks. Now, next thing is discussion 2. Discussion 2 is on the clinical implication. What is clinical implication? Clinical implication means due to this problem, what can happen to the patient in near future? Anticipated problems. What is expected? What it may lead to? If the condition is progresses, what are the problems it may happen to the patient? Possibly on the ADL, activity of daily life. How it affects the patient's daily life. Getting? Many of the students getting confusion over the clinical implication. Many of the students getting confusion over the clinical implication, how to write the clinical implication. So I am repeating again, clinical implication is what might happen to the patient due to this condition. What are the consequences? What are the consequences of this condition to the patient? How this problem affects the patient's life, activity of daily life. That is clinical implication. Is it clear? Everyone, those in online also, please make it clear, because from the previous experience, where I feel the patient lacks or misunderstanding will be on the clinical implication. They can't understand what the clinical implication is, and they give some other information which is not needed there. This is how you have to explain the clinical implication. Again, as I told you before, everything need evidence. Okay, if you're saying that it affects this way, ADL of the patient is affected, like patient is unable to walk, patient unable to carry weight, patient not unable to do the daily activities. Whatever you say, it has to be based on evidence. Okay, it is not based upon your thinking. It has to be based on the evidence. Next is management. Only physiotherapy management. Please make it sure. Understand that only physiotherapy management, no medical management, nothing. Only physiotherapy management. As a physio, how you're going to manage this condition? That's all. Your management can include both ectotherapy and manual skills. Okay. In real life situation, how you're going to handle this patient, that management. So all your management has to be explained how that management improves the patient condition. Getting? If you are applying taping means how taping improves the condition. If I applying STM means how STM improves the condition. So for all the treatment, you have to explain how it will improve the patient problem with evidence. Evidence based, everything I told you no. Okay, all your whatever you mention in your presentation has to be evidence based. Any number of treatment and all the treatment has to be recent within 5 years evidence. This carries 25 marks. Next is conclusion and summary. Just summarize everything from the condition and your treatment, right? Summarize it. Plus future management. What kind of future management is needed apart from physiotherapy? Apart from physiotherapy, in future, what type of treatment is needed for the patient? If any surgery is needed. Understood? So surgery means what surgery can benefit the patient? Yes. Okay. Explain the future management, possible future management for this patient. That again, you have to give evidence for that.
Minimum 5.
No, years, within 5 years.
How many article or litigation?
That is up to you. Up to you. But make sure all articles are within 5 years. Okay. Next is Viva. So 10 minutes you have to complete out the presentation. After 10 minutes, you have be having 5 minutes of discussion. In discussion, minimum 3 questions. That is how you say this is the possible problem of the patient. Your hypothesis, your condition. Like you're saying carpal tunnel syndrome, or if you're saying this is a TFCC injury, how you say this is a TFCC injury? What is the rationale? You have to give answer for that. Then what structures will be affected by this condition? Okay, what structures affected by this condition? And the problems of this scenario, you have to rationalize that. Okay, based on that. Next is rationale for the treatment. Why you provided this particular treatment? How that improves the patient condition? You have to provide a rationale for that. This will be discussion. In case the examiner feels you don't have any knowledge about the anatomy and physiology structure, question also can be asked about the anatomy. This all depends upon you. So during the presentation, if the examiner feels that the student is lacking anatomy, yes, examiner have the rights to ask about the anatomy and physiology also. asking where is attachment, what is the function, how it get injured, all that also can be asked. Right? This carries 20 marks. Finally, the presentation, how you present your presentation, your clarity in the presentation, the clarity in the slides, right? I told you no, the size, visibility of the slides, okay, how you presented the informations, your referencing, all carries 10% or 10 marks. If you have any questions, please clarify. Yeah.
This one says ETP 6223. So the cases will be either MS or neuro.
MS.
Yes, sir. Thank you.
So when we will get the
Question.
the question.
15 days before, 2 weeks time. When is the exam?
The presentation is 31st June.
21st June. Okay, so first week of June I will give you. Okay. First week of June. First week. Okay. You can text me if I am not giving uploading. I will upload the LMS. In case if it is not done, please remind me.
Basically like a subject presentation, everything is subject.
Any other questions on the? How I can give example is you have to write.